Good morning, ladies and gentlemen. Thank you to Rero and Sir John for sharing your insights with us and really setting the stage for the next 2 days. We're really grateful to have the two of you on board as co-conveners for this year's forum. With that, I'd like to introduce our next speaker, Dr. Trevor Mundel. As President of Global Health at the Bill and Melinda Gates Foundation, Dr. Mundel leads the Foundation's efforts to develop high-impact interventions against the leading causes of death and disability in developing countries. With his talk, titled Fighting Tomorrow's Inequities, Innovation and the Future of Global Health, we're looking forward to hearing more his experience at the Gates Foundation and how he envisions the future on a global scale. Please welcome to the stage Dr. Trevor Mundel.
Thank you, Jonas, and thank you to John and the organizing committee for inviting me to come and spend some time. I see a lot of old friends in the audience over here. And I think, to Rero, John, you actually set the stage wonderfully for some of the things I'm going to talk about. So I can focus down on some of the work that we've been doing, but bearing this broader context in mind. So I called this Fighting Tomorrow's Inequities, and I hope that that theme is going to become apparent as we walk through some of the presentation. And hopefully we have enough time left for some good discussion afterwards. I know that I'm keen to get your feedback and understand how you see this work and think about the Gates Foundation. So if I step this forward. So I often put up this slide before getting into the technicalities of what we do and how we think about our work. This principal premise of equity and everybody deserves an equal opportunity for a healthy, productive life has been one which I think by focusing on it in the first instance has given us tremendous, in effect, non-aligned access to governments and multilateral organizations. So as much as we've been doing specific things, it's all been predicated on having this access and partners to do it with, particularly at this governmental and international global health level. I wanted to put up this slide from the IHME work, Institute for Health Metrics and Evaluation, Chris Murray's group. And what it shows are the disability-adjusted life years per 100,000 in the low SDI, that's socio-demographic index countries. That's a new metric which has been introduced by Chris's group, which seems to better reflect the dynamics of health outcomes. It includes three major factors: GDP, educational attainment, and fertility rates. Now, what you see over here is the infectious, the communicable diseases between 1990 and 2016 still dominate in these poorest of countries, because I frequently get this question of why does Gates focus on communicable diseases when we know that there's this explosion of metabolic disease, hypertension. And I recognize, though, that even in these poorest of countries, you see the uptick of cardiovascular diseases, and we no doubt will see a range of other non-communicable diseases become progressively more important. And we have one aspect of our program around pregnancy and early life, which very much intersects with this whole area of non-communicable diseases. So thinking about the problems we have in terms of the future, recently we had this goalkeepers event at the United Nations General Assembly. And we presented from the 100-plus SDG goals that the United Nations has adopted, a subset of really 17 key goals around health and other factors like poverty, which we felt needed to be called out. And we'd been working, so I'd been working with Chris for the last couple of years on some way in which we can present the data where people can see what the trajectory is. And we can use it both as a way of judging what we and others are actually accomplishing, but also what the upsides and the downsides might be so that we can kind of adjust to the future. because almost everything that we're working on in the innovation space is projected into a 10-year future. And it is so easy to think in that 10-year future that whatever you're doing now may actually be completely misdirected if you're not trying to gaze into this crystal ball. So the way we've done this is you can see that, first of all, the dramatic improvement, which is, we'll talk about some of those factors, but many factors, particularly in the socio-economic development world, leading to this more than halving of kids that are dying under the age of 5. But if we project out to 2030, you have your estimate of where you're going to land, which is a halving, which is good, but you still have 2.5 million kids dying, which is a tremendous number. And that doesn't include the big number left out of this chart are stillbirths. And stillbirths, probably another 2 million. And what exactly is a stillbirth? You can probably add that in over there. But the way of looking at it is with the red, which indicates the downside of where we might end up if things don't turn out well. So this is just done by projecting, taking the important covariates and varying them between the 25% and the 75 decile percent of that covariate, which is impactful on the health outcome. So this is taking it at the 25%. You get to this downside. The green is the upside, where we could get to if things went better than expected. And you can see the difference is really 1.3 million lives. So, I think that this is a useful way to look out into the future, and it seemed to get a lot of traction with the folks in New York. Let's just put up, what might be a not complete solution, but I certainly would pack up and go and do some other things if we could solve this problem. You can see what the goal is in 2030 amongst the SDG goals, and you can see what the projection is, which means that there are going to be an awful lot of people that are still in desperate circumstances and, unfortunately, significant problems to be encountered in this 2030 world. Okay, so we could wait for development, which almost certainly over decades will take care of many of these global health problems. Or we could intervene now. And I believe that the way to intervene now is to apply the scientific knowledge, backed with some common sense, to the problems of global health, as much as that scientific knowledge has been directed towards the health problems of the rich world. And I think that that can give us much more rapid gains instead of waiting for the general development of infrastructure and healthcare systems, for instance, to take care of the problem. So that is the argument I'd like to convince you of. In terms of the things that you could do, one of the most frequent questions that I get is, why do you work on these set of projects? Are they sort of randomly picked because Bill and Melinda Gates likes that thing, or they read a newspaper article about rotavirus, so that's why you work on the rotavirus vaccine? It's sort of arbitrary. Or people come and lobby. There is a lot of that. But, one of the ways we've tried to get around that, and it's not perfect, and it's used, I'll explain to you how it's used, is this, this bubble chart. And I'll just quickly run through some of the elements of this. So the bubble size is the total DALY burden that's being addressed. And you can see over here, this is roughly the size of 100 million DALYs. We're looking at two axes over here, and there's really another third axis. So the one axis is the very subjective probability of technical success. So there's some things, it would be wonderful if we had an HIV vaccine. In fact, let's even take something which I think is less likely, a TB vaccine that was highly effective. Wonderful to have that, and that would fix the TB problem. The probability of that happening is extremely low. So let's not get into whether it's 1% or it's 5%. Then there's the aspect with a limited amount of resource. How do you best allocate that? So if you're picking between two things to do, and they could be radically different, bed nets, a third bed net in a family in Zambia has been shown to actually further reduce malaria. So would we rather give a family a third bed net, or would we rather focus on making a vaccine for malaria? You have to judge between those. So we have this cost effectiveness. How many dollars would you pay to avert one DALY, 1 year of death and disability? And fortunately, we have some pretty good comparators. So for instance, voluntary medical male circumcision, that bubble up there, addressing a huge problem in terms of DALYs, is actually cost-saving because people don't become infected, they don't get opportunistic infections, they don't get into the hospital system. So it's cost-saving, so we have that. So we also have, it's not on here, but bed nets for malaria, blocking malaria transmission. That costs about $100 per DALY saved. So that's highly cost-effective. Then you have all of these other bubbles that break out. Now, the truth is the data is so imperfect that each of these bubbles should be in a big cloud of uncertainty, right? So there's no ways you can use something like this to be definitive in terms of what you do. But I think it can prevent you from making big mistakes. So you look at this little almost imperceptible dot over there, which says hookworm vaccine. So when I arrived, we had this project to develop a hookworm vaccine. Now, hookworm is a pretty big problem. It causes anemia, and it's been linked to a lot of disability in kids. It's rife in many areas. It is effectively managed by the Mass Drug Administration of a highly effective drug called albendazole. So the other thing about the bubbles is that they are bubbles compared to the standard of care. So that's why that bubble is so small. And you can see it be about $10,000, whether it's $10,000 or it's $7,000 per DALY averted. It's because there's an existing effective intervention, and then the probability of success, I would suggest you put it much lower. Is there a worm vaccine right now? Well, there is in animals, but there's not an example of a worm vaccine in humans. So low likelihood you get a very effective vaccine. So when I saw that little bubble, we had to get rid of that, much to the chagrin of the investigator who was super invested, as people are in these projects, but we eliminated the hookworm vaccine project. So an analysis like this can at least get you out of doing bad things. It's not a definitive way of picking exactly what to do. I wanted to focus on the big three infectious diseases, the focus of the Global Fund. And just to come at them with a snapshot on two fronts. One is to suggest one of the major macro problems that is relevant to that disease. And then to suggest what I see as one of the new opportunities in terms of addressing that problem. So it's a challenge. Pick one of these and we'll have a debate as to, I'm sure, many other options and many other selections from that perspective. So let's take malaria. And if we go back in the history, this is 1990. So I joined the foundation about 6 years ago, and it was an interesting time for malaria because we were in the midst of the malaria data wars. And that was, the IHME group had estimated that there were 1.1 million deaths from malaria, of which 500,000 were in adults. And this was hotly disputed by the malaria community, who said that there were only 600,000 deaths, and that basically adults don't die from malaria. So that is a massive difference, 1.1 million or 600,000. And the world has now converged somewhat. So we have the malaria problem as it exists now, with about 450,000 deaths. But they are very focused. Those deaths occur here from falciparum malaria, and they occur by and large in kids under the age of 5. So it's very clear what the malaria problem is from that perspective. In terms of one of the big background factors, this one comes up all the time, and this is the changing environment. And I want to put this in a bit of a broader context than just climate change. So it is true for the first time that we introduced into the global burden of disease temperature as a risk factor. And you can see the potential for areas that might sustain malaria transmission expanding with the climate changing. This is not a very simple thing to understand. And there are a set of highly nonlinear effects. So it is the case when you raise temperature, there are two factors you have over here. You have the mosquito vector and you have the parasite. As you raise temperature, the parasite accelerates its life cycle through the mosquito. It takes about 8 to 14 days to mature in the mosquito before it's present in the salivary glands to infect people when the mosquito is feeding, female mosquitoes are feeding. So that's a race for the parasite because the mosquito only lives about 21 days. So if you have a lot of old mosquitoes, then they have time for the parasite to mature and they become more infective. So the total mosquito population is very infective. But this tension between the cycle time of the parasite life cycle and the age of the mosquito is highly nonlinear. So it's not true for the same rise in mean temperature. If you have oscillations and different variations in that temperature, you get the same kind of infectivity for your total mass of mosquito population. But nevertheless, I would also include in changing environment is the incredible turmoil in exactly those regions that are going to be the last frontiers of malaria, whether this be in Myanmar, whether it be in Congo, Democratic Republic of Congo, where we see the increasing problems in the eastern part, or it be in the north of Nigeria. So in these final homes that will be the last frontier, we see the greatest instability in the environment. So it's this environmental problem, both physical and social, which is a huge backdrop to the malaria problem. Let's look at the future projection over here. So this one is a pretty interesting projection because this one has got the biggest divergence between upside and downside. And the depressing thing about this is that the projection of where we are likely to be in 2030 is actually not any different really than today. We could be back up at the peak of infection, and usually this downside comes from a funding aspect if we don't adequately fund even the existing degree of control. But what is the exciting thing for me is that if we do some things right, we can actually be down dramatically, even beyond the goal that has been set by the SDGs. So malaria has got this sort of depressing expectation, but it's got a huge upside. And how are we going to access that? Well, because of that upside that you saw, there's an explosion of activity in terms of developing new interventions. Whether this be new insecticides, there are going to be 2 approved this year. We already have pre-qualification for one of the new insecticides, given this rife problem of pyrethroid resistance. There are new ways to change mosquito populations, whereby we may crash the populations. The first release of a modified mosquito will occur this year in Burkina Faso in December, and then we'll see how that plays out. There are many drugs in the pipeline, and you may know that the first vaccine that was introduced and in a large study actually demonstrated efficacy, modest efficacy, 30% like efficacy, which is not good enough to broadly deploy it, but proved the principle that you can have a vaccine against malaria. That one just doesn't have the durability. So I think the second generation vaccine, actually maybe even targeted to exactly the same target, is looking quite hopeful. So we have all these possibilities. How do we actually put that together? I have these teams who come up and say we need to do more observational research for malaria, and we need to try combinations of extra bed nets, more indoor residual spraying, more vector control here, plus we'll do mass drug administration in targeted. So there are 10 plus interventions. What has become possible for us over the last couple of years is to do realistic, full-scale simulations of the malaria epidemic, whereby we take the geography from geospatial mapping, we take the vector populations, we take the immunity in that actual existing population of people, all the different parasites that are genetically characterized, and we can put them into these massive simulations which have never been possible before, and we can simulate an entire country. Now, that is one way in which you can test these different combinations instead of doing at the outset these operations research studies which can take 5 years plus, and you have tested essentially 1 or 2 set of options out of the combinatorial, ramp up from the 10 potential options. And that has started to become feasible, and I think that that is the way. Malaria will be the first instance in which we see this really becoming feasible. So this is Madagascar, and you see a simulation of, actually it is the vectors and infected vectors, and the ebb and flow of the highlights is during the rainy season, infected mosquitoes, or the infection of mosquitoes ramps up from the coastal areas into the central highlands. Now, you may be aware about another thing, which is it's from these central highlands that tragically the 31-year-old young man presented to the capital in Madagascar with pneumonic plague. So we have this outbreak of pneumonic plague right now in Madagascar, but it looks like it is waning. So I'm hopeful that that will be a problem that will resolve. But this ability for these full-scale simulations, very realistic, gives us this opportunity to triage the many interventions and make rational decisions. We'll still need operations research, but at least it can be focused and targeted. TB. I put up these historical graphs of the TB problem here in the UK and in the US, New York City. Now, this is mortality per 100,000, and what I'll show you subsequently, the numbers that you see usually bandied about are incidents per 100,000, but take into account that in this time, about 70% of people who got TB died. So, the incidence that you see now is comparable because were there no treatment, which is actually pretty effective, about 70% of those people would die. So there is some translation between these incident numbers and this mortality representation. But the dramatic thing over here is that all of the big declines, New York for instance, occurred prior to the introduction of effective drugs to treat TB, before there were effective treatments. And there were a combination of factors, whether it be a little bit of, and there's debate about this, whether how important infection control was, but certainly improving environments, housing, water, sanitation, and nutrition were major factors. So you can plummet the TB problem just by having those factors in place. And TB, out of all the diseases, is the quintessential disease of poverty. That is absolutely at the root cause. Take that out of the equation, and you will not have the TB problem that we have, which is expanding. So that is the big background to TB. I guess the depressing thing about TB, when you now look at the future world, is this has got the biggest divergence between this goal, which is actually a WHO goal, the rollback or the Stop TB group there. But you see that there's no likelihood we're going to hit that goal, basically. And we're going to continue on this slight improvement for the next, if nothing else happens, slight improvement over the next 100 years with TB, basically. So what we need over here is some new thinking. And I think it needs to be in a particular area. So whenever we look at the cascades of care for TB, person is out there, they have TB, they come into the healthcare system, what happens? There's a massive deficiency on testing. People do not get tested. I was just back from South Africa where we have a study looking at a new set of biomarkers which have the potential for identifying whether somebody has got TB 1 year before they actually become active or actively diagnosed. And they were amazed in the study because within the first few hundred people, they had 30 people who passed their screening. So the screening is, you feel completely well, you have no symptoms, no night sweats, no cough, no weight loss. Then you get into the study, and then they ask you to generate a sputum sample. And you might wonder, how do you generate a sputum sample if you're totally well? Well, it turns out that most people can. So in any case, you generate your sputum sample. I suppose that is biased towards people who actually have some issue. And 30 people had active sputum-positive TB who were completely walking well, presumably around infecting everybody. So there is the silent part of TB, which is very difficult to ferret out. But there's a massive lack of actually testing people, and we need the right kinds of tests. So I want to show you something which is a little bit off track in some ways because it is so tangential. But it's exactly the kind of new thinking which I think is really exciting. So I met up with, at our Grand Challenges meeting in DC a couple of weeks ago with a young man from Stanford, Riju Das, who is a technologist but knows quite a lot about biology. And he set up a web-based enterprise called the Eterna game, whereby he gamifies challenges, whether they be health challenges, other challenges, and asks gamers to participate and solve the problem. And he does it around RNA folding, ribonucleic acid folding. Now, the reason that he does it around ribonucleic acid folding is that RNA, unlike DNA, its secondary structure and how it folds is very difficult for computer algorithms to predict because it can have many stems and many configurations. Now, I'm not talking about natural RNA in cells. I'm talking about artificial RNA, what you could make of it, because the machines have to take into account all the possible configurations of the RNA molecule. And it has been impossible computationally to have accurate predictions with the existing algorithms. What he has found is that expert computer gamers are able to solve this problem. They are able to predict better than any of the existing algorithms what the folding structure, the secondary structure of RNA is. And it's not just one. So he has a competition. The gamers submit their solutions. He picks the 10 best solutions. And then he actually makes the RNA to test whether that solution worked out. And typically he gets a number of these gamers who come up with the perfect solution to the folding you want of the molecule. So what was this problem over here? So I'm going to show you this, and then I'll explain to you what happened over here. So we play the game, and this is our RNA molecule over here, and it's interacting with other RNA molecules. And what you have to do is you have to predict how it's going to fold during the interaction. So the interesting thing is here, we found that there were 3 message RNA sequences in blood. You could get them from blood cells, 3, that when looked at in the right equation, did this thing that I told you about. It predicted 1 year ahead whether you would become active. But unfortunately, you've got to solve this little equations. You've got these 3 factors, you've got to measure them, and the equation is x plus y over z squared. That's the equation you have to solve. Now, we're thinking about how do we make a diagnostic that does that? Well, he said, well, let's make an RNA switch. What if we can get an RNA molecule, when it hits exactly that equational stoichiometry of those 3 RNAs, it flips into a new configuration which you can read out with fluorescence. But it was very difficult. He knew the final configuration, but how do you get a molecule which would flip when it hits that right configuration? He put the problem out. 10 gamers had the perfect solution. So we're trying to turn this now into a diagnostic test. And it's this kind of orthogonal thinking that I think will get us to some interesting places and beat the depressing picture for TB. On the HIV front, so here we have an issue. I wouldn't say, now, this is where we're going. We have the peak of the epidemic. We had PEPFAR and this funding, which is so critical to things. The big picture problem is this downside from funding. And the problem highlighted here in this thin white line, you could say, is sort of the Trump effect. That would be if the 10% cut to the State Department were enacted that has been proposed at some point in time. So dramatic and tragic consequences from that defunding of HIV treatment programs, essentially. That is the big picture problem that we're looking at. The other problem we have is the demographic dividend, which is going to be tremendous in Africa, now emerging as it tails off in Asia. But what it does is it brings tens of millions of young people in the 0 to 24 age group into the high-risk group for HIV infection. So out of all of the things the other two diseases I've talked about today, there will be more people infected with HIV in 2035 unless there be some dramatic intervention, whereas in all those others, there will be less of a problem. So in terms of percentage of population, in terms of incidence, yes, going down. With the demographic dividend, a bigger population of people infected. Well, what are we going to do about that? I just want to mention one population. Adolescent girls in Southern Africa are a particularly vulnerable population. And to date, we haven't had effective interventions. We've had various microbicides, which have been partially effective, gels. We have a ring, dapivirine ring, which is a vaginal ring, but very partially effective. What are we going to do? I'm hopeful of this technology. So this is a contraceptive implant. There is a company that has been developing implants for diabetes. It's called Intasia. And they have a version of this, which is actually a little titanium one about this size, that you can implant right now for 6 months, but it can be a year. And we have some very long-acting antiretrovirals, particularly the new versions of tenofovir, that we can formulate. You need just 100 milligrams, would cover you, if it delivered in the right way, for an entire year. So absent that we have an actual vaccine, we believe that a suitably formatted implant that would cover people for a year will be another type of intervention which will get away from the issue that PrEP, pre-exposure prophylaxis, has typically not worked well in most of the studies we've conducted in these populations. Okay, we've talked about the big three infections, and we come to technology. Does it have a role? I believe it does in this acceleration. But it's got to be appropriate technology, and I think that's an obvious statement. And I would say that if we've made mistakes in this area, and we've made a number of mistakes, it's that we have not understood that community, that patient journey very well, and we've produced these sort of somewhat mindless technologies which we've tried to impose on people that didn't fit the circumstances. And what I've discovered in this is not a situation where your marketing group can overcome the deficiencies of your product, as you might if you had a product in the US and Europe. You know it's deficient, and the marketing group will somehow find some great campaign. If you miss the profile that's appropriate, the miss can be complete, so the thing can be zero. It's not that you get a partial effect. The diagnostic that was supposed to be point of care, well, the fact that it takes 2 hours to actually test, I'm talking about the Cepheid gene expert for TB nucleic acid diagnosis. We thought it was going to be point of care, turned out to be not bad, but not point of care. And it's actually zero in terms of impact. So finally, I just want to put up what is part of the joy and consumes a lot of my time in the global health space, which is that there are a sea of passionate partners. Every time I put this up, we add somebody over there. I think Ira, who is over here, knows well the difficulty of putting together coalitions amongst this partner group and keeping those coalitions going. But the passion that they bring to the exercise is tremendously positive. So with that, I wanted to conclude my talk and open up for some questions.
Thank you, Trevor. I think we'll have about 10, maybe 15 minutes at most for questions. We have Alex and Sherelle who will be carrying some mics around. So if you want to ask a question, please put up your hand and we'll get the mics to you.
Yeah, hi. Jonas, and then
yeah, hi. Very interested in your talk. I'm an Atlantic Fellow and I'm a neuroscientist. I would like to understand better how you calculate these upsides and downsides visualizations that you were showing us. Is this some secret art, or how do you actually calculate those numbers that you showed?
How do we get those numbers?
Yeah, upsides and downside visualizations between the...
Where do they come from?
Yeah.
Right. So they're very simply generated. You take the covariates that are impactful for the projection, that are significant for the projection, and you just vary them between their 25th and 75th amount. If you take sort of 100% effect, you vary, well, 50% is the median effect, which gives you your estimate. You just vary them 25% plus on the upside, 25% down on the downside. And you don't do combinations, you just do them individually, right? Or just do the whole lot of them. You're not doing subsets and complex things. So it's actually a very simple projection. It's kind of a linear projection by just varying them between those ranges. What it emits, I mean, you point to some very good points. So we don't have in there things like, we should introduce that there would be some new interventions with a certain probability in the next 10 years. That would give you a further upside. And on the downside, we didn't have that there may be a pandemic outbreak or a regional epidemic which would crash the healthcare system. So I would say that these are kind of conservative bounds, and really the bounds, if you put in all the other factors, would be much broader. Thank you. John, you had a...
Yeah, so Trevor, I wanted to talk to you about something I think is really fundamental, and you showed some interesting examples, but we're having a big debate in the UK at the moment about how you source really exciting new innovations into an innovation ecosystem, as it were. Because I think what everybody's realized is the conventional way about making decisions about what you do and what you don't do, if you do it in the way that most of the research funders do, particularly public sector research funders, you gradually get more and more boring science, and you don't end up with really exciting breakthrough. And you guys have been better, and I think the gaming thing is a really good example of sourcing people who are outside the conventional system and then making decisions about how you fund them. But it'd be interesting to hear your thoughts, because that ultimately your success in this space will entirely depend on getting smart people with really high risk, but potentially hugely impactful innovations into play. And the public sector systems don't do that. So I'd be interested to hear your thoughts about how you make that work.
No, John, that's a key question. And actually, you know, Lucas, you mentioned John's other activities. One of these very important activities for us, he's been the chair of our scientific advisory committee for the last 6 years very effectively. So the one way we've been looking at this on the science front. So I think we've got a very solid science group, very much immersed in where the science is for TB, all of these diseases on the immune side. And my expectation of them is that they actually move us into the adjacencies. So they look at new opportunities which are adjacent to existing science. And I don't want them, some people have this notion, and even some of them have the notion, that they want to be more venture investors, just take wild flyers. Actually, I don't want my solid science group to be taking wild flyers on things that don't come from a rational extension from existing science. So we have another group now, which is the DARPA-like group. We recruited somebody from this DARPA group in the US, which is a group they've had associated with the Department of Defense, which has this incredibly free approach to making investments in new ideas. Essentially, a particular officer in that group gets a pot of money, and they're almost entirely free how to allocate it. And they can do it even within governmental systems very rapidly, within a week or two. And we took one of the people who've been very effective in that system. So now we get into the situation. We have solid science and adjacencies. Then we have flyers. Now, those flyers are things that, by definition, actually, if you've got a group of current scientists, they would say, that's crazy, right? If you can get a group of current scientists to say, well, that's a good idea, it makes complete sense, then by definition, it's not a flyer. How do you work in the space of flyers? Hail Marys, whatever you want to call them. If you have to make a big investment, you're going to lose the game. If you've got to put $5 million in to find out whether that works, you're going to lose the game, because those things it's going to be 1 in 40, 1 in 50 of those things that actually make sense. So you have to have a phase which I'd call prototyping, whereby you can make a very small grant, $100,000, and you can do the definitive small experiment to understand whether that thing has got traction before you upscale it. And there is a remarkable skill that some people have to do that. It goes completely counter to the academic enterprise, because the academic enterprise is just looking at getting big, long-term, sustainable grants to have lots of postdocs and do lots of research and make lots of publications, and nothing comes of that, actually. So this is orthogonal to that academic enterprise, but that prototype into the flyers group is the critical piece. Yes? Hi.
Okay, is that working? So thank you very much for your talk. I had 2 questions. One question I found very interesting about the vulnerability of adolescent girls and this harm reduction approach with the implant of antiretroviral. I was just wondering whether the foundation is also working more broadly on that spectrum, what they can do about gender equity, about reduction of sexual violence, and all of these other things. Obviously, harm reduction is important, but it's just one approach among a continuum of approaches. So that was one question. And the second question, I was interested about the prioritization of how you choose to make your investments and where you focus. Obviously, certain technological advances like vaccines can have huge impacts on global health. I work a lot in indigenous health, and there's a saying, nothing for me without me. And the engagement of the public and of the people on the receiving end in actually being involved in helping to make those even priority setting decisions. And I was just wondering to what extent you do engage the people who will be on the receiving end and how they are involved in setting these agendas.
No, those are 2 great questions. Let's take the first question around the implant and the other factors, the violence that these young girls encounter in their environments and the biases that they have to face. So let's say we make this implant, and then we say, there's a great implant, it can protect you from HIV. I would project almost 0 uptake of that. I mean, there's currently PrEP, and there's no real desire for that. Even family planning in these areas has a very low coverage. So we're going to get 0 uptake, but that we have to engage with those communities, those young girls. We need to understand their lives, and we need to make this relevant to their lives and these factors, which are much more important to them. The notion that they have this implant or not have this implant. I mean, I was chatting with some of these young girls in my trip last year down to Durban. And they had this, and was asking them about why wouldn't you use PrEP, and why would you make yourself vulnerable to HIV? They all were aware of HIV and of the problem. And they said, well, if we do PrEP, we'd have to take some pills every day. If we get infected, there's treatment, we'll take the pills then. So they had some of them had this completely different perspective. So you're completely right that this will be 0 unless we understand their lives and what matters to them. On the other thing of community engagement, I think the best example that I've seen from the work we've done has been in the Wolbachia mosquito, Aedes mosquito project, where we've developed this variant of the Aedes mosquito, which is infected by this bacterium Wolbachia, which doesn't transmit dengue or Zika. And we've been doing studies in Indonesia, but now a big study in Colombia, and down in Rio, there's pretty broad-scale release of these mosquitoes now. Now, you think about, so with the proposition to the communities, we're going to come in here, and we're going to release a bunch of mosquitoes. These are female mosquitoes as well as male mosquitoes. So you're going to get bitten a lot more. But don't worry about it, because these are good mosquitoes. The other ones that are around you are bad mosquitoes. That is not a proposition that is easily accepted. So the amount of community engagement that has been necessary, particularly in Indonesia through traditional leaders, for instance, to explain to the population, yes, there's going to be this release of mosquitoes, but this is the consequences you'll see. And the acceptance of that has been tremendous. And that program has really defined for me the sort of the high point of real community engagement.
I think we'll have time for maybe one last question, maybe one from a current scholar. Tinashe seems keen to ask a question.
It's all right. Can you hear me? I won't need a microphone. First of all, I'd like to start with what's good better, because we do like design thinking, which is everything that you've mentioned so far. But actually, I'm very concerned. When I see your slides, I'm very concerned about the future. The future, particularly for developing countries where you're working at. I work with a time scale of 2055. That's the year I may retire. No, it's very important. Look at it this way. Let's say we achieve all the things you've said in malaria, and we get to a point where there's 9 deaths per 1,000. I think that was the figure. And the Bill and Melinda Gates Foundation has succeeded in what it's done. You've gotten great kids from New York to come in, develop innovative ideas that have transformed the care of malaria. Then there's me, halfway through my career, maybe working in some government office in South Africa, trying to plow my way to being Minister of Health. Being honest. But now what you've done is you've achieved your target, but I don't have partners to work with in governments around me, because what you've essentially done is you've outsourced innovation. You've killed the pool that I would have had access to, which is talented people, funds, units that would have developed in our own countries, such that by the time that it's 2055, I have to pass on the legacy of that uptick to my mentees. What is the Bill and Melinda Gates Foundation doing to build real capacity in the governments that you're working with? So that in the areas that you aren't targeting, such as trauma, which is surgery, which is about a quarter of what we face, most of our young doctors are dealing with stab wounds. In the areas that you aren't funding, because you've skewed the ecosystem towards the areas where you're acting, whether it be in research or in new institutions that are built, what are you doing to mitigate the cost of what you're not looking at in the ecosystem of healthcare?
That's an excellent question, yeah. And it troubles me a lot, because you're completely right in terms of the ecosystem that has existed with these elite university systems, Hopkins, UCSF, with tremendous resources, who set up consortia and involve investigators, say from Africa, and develop massive databases which are then mined for careers, mostly on that side, leaving in some ways residuals for the actual people on the ground who are doing that kind of work. So I hate that kind of system. And what we've been working on in terms of open access and open data, and now the preprint initiative is intended to break down that system. People have ownership of these databases, often in these elite organizations, which they hold on to for years and years and mine for careers. So we need to break that system down. There are other elements around the capacity building that I think we are committed to from one perspective very strongly, which is wherever we can, in doing any of this work, as a benefit, actually develop capacities in country and in Africa, we need to be doing that. So one of the enterprises that I've most liked is our partnership with the Wellcome Trust around an enterprise called AISA, Alliance for Excellence in Science in Africa, which is based in Nairobi. Now, the notion of that is that there is funding around grand challenges for people, for African scientists to put proposals forward for things like the RNA thing, the Eterna thing, and the funding to come from the group that runs AISA, which is Nairobi African Academy of Sciences based, and does not have the NIH or us or the Wellcome Trust deciding who gets funded. And they have the first big round of their awards coming out now. So I think that, you know, in terms of this work needing to carry a very strong component of capacity building, so there will be the scientists in Africa that will hopefully sustain you in your old age and your retirement. And boy, in terms of the, the country, the South African aspect, Minister of Health over there, have I got some projects for you in terms of, yeah, afterwards, let's chat.
Unfortunately, we've run out of time, but I'd like to really thank Trevor for this excellent talk. I don't think we could have asked for a more appropriate and insightful start to the weekend, so thank you very much.